So I will show some interesting angiograms where you have to make diagnosis and decide how to manage on the spot. This is the case of an 80-year-old man. He's coming for an elective coronary angiogram pre-TAVR. He's not having any ongoing symptoms. So this is the first image of his coronary angiogram done transradially. This is an ariocaudal, and you see he has an old LAD stent. Look at it carefully, and what's the problem here? This is another image. This is a shallow ariocranial. And this is the eleocranial. So again, what's the diagnosis here? The LED is occluded. What is this? Is this a CTO? I will add that immediately at that first injection, the patient started to become uncomfortable and complains of chest discomfort. We can also see that he's having some ST elevation in lead 1 on the monitor. What's the differential diagnosis? So I want you to think, is this an acute or a chronic occlusion? So it is an acute occlusion. Both the appearance of it and the fact the patient became uncomfortable suggests it's acute. It's not chronic. In a chronic occlusion, there is usually a well-defined cap or cap area. The cap might be ambiguous, but it will be a well-defined zone. This is clearly a moving, a blurry cap. This is how a chronic occlusion is. Well-demarcated cap, or not well-demarcated, but a well-demarcated zone with the branches around it, and usually some collateral reconstitution. Now, he might have collateral from the right, but usually collaterals form from the neighborhood. So you should have some collaterals from that OM distally to the apex of the LAD if this was chronic, typically. So this is an acute occlusion, angiographically and clinically. What caused it? You have to know at least the 3 differential diagnoses of acute occlusion during your angiogram. The first one is, yes, a clot formation in your catheter or an atheroma that you cut from the aorta and you injected it. The second differential diagnosis is dissection. But typically, dissection starts at the guide. So you engage, maybe it was a difficult engagement, and you will dissect from the left main all the way down. But this doesn't look like a dissection. If you look at the images, there is no dye stain. Usually dissection, you will see double lumen with dye hang up. There is no such thing here. Now, could it be a thrombus? A thrombus also typically, a fresh thrombus will grab on to contrast. So you will see dye stain, dye hang up in that area. This doesn't look like it. Between injections, I don't see any dye hanging. So it is the third differential diagnosis, which is air embolism. And actually, if you look carefully at the first image, you can see the air coming from the guide. So whenever you suspect air, you can look back at that first shot and see if air is moving from the catheter into the coronary. And you can see it here. Look again at the beginning of the shot. Here, exactly. You see it? Here. This is the air before the injection, that white inside the black contrast. Now you inject and the air is moving and it got stuck in the mid-LAD. Another thing that supports that is that it's getting progressively more distal with further injections. Look, here is getting more distal than the prior shot. If you use your diagonal as references, it's getting progressively more distal. And on the third image, it's even more distal. Another thing you should look for more carefully whenever you suspect embolism, whether air or thrombotic embolism, is involvement of other branches. And you can see here that septal, that trifurcates, there is involvement of all the branches. There is to and fro movement in those branches, suggestive specifically of air embolism. They are occluded with a to and fro movement. There is actually involvement also of that high diagonal and of that other diagonal. They are all shut off by air embolism. And none of them stain with dye, which suggests, again, air embolism. The question now is how to manage air embolism. The most important immediate next step are twofold. One, high flow oxygen, and I will explain how this works. You put him on 100% face mask of O2, regardless of what's his oxygen saturation. And number two, you support him hemodynamically. If that air embolus is very distal, it may not affect him hemodynamically. If the air embolus is proximal, the patient may have hypotension, hemodynamic collapse, ventricular fibrillation, or cardiac arrest. You support him hemodynamically. Those are the two first most important steps. Now, if the air bubbles are distal, mid to distal, as in this case, the best strategy is not to aspirate them, because air bubble leads to hemodynamic compromise and death, mainly when they are proximal, in the left main or the proximal vessels. This is not the case here. So the best thing is to inject and saline or contrast and push. This is what you call the push technique. So you push those bubbles distally and let them disperse distally, then break down distally. If the air bubbles are very proximal and they are causing hemodynamic compromise, then you can suck through your guide, suck forcefully, maybe even deeply engage with your guide and suck forcefully. So those are kind of the two big strategies, depending whether they are distal or proximal. Another thing that contrast does, as I explained in a prior talk, it is a microvascular dilator. So it will open up the microcirculation. You push the bubble, you break them down, then the microcirculation is more open and it will absorb those bubbles. Okay? So this is what was done in this case. And within 2 minutes, on repeat angiogram, look at that. This is just with O2 and with pushing the bubble with contrast. Look at that septal, how nice and big it is. And look at that LED. It's filling all the way down to the apex. And look at that diagonal also. It has no occlusion anymore. This is another view. This is a more steep areocranial. Again, everything is filling very robustly. I want you to know, how does air embolism happen? In a diagnostic case such as this one, it happens from improper catheter aspiration and flushing. And you may particularly suck air when the catheter is against the wall, even temporarily against the wall. You suck air as you're aspirating. Some of the air will remain in the catheter. Another possibility is that there was air in the manifold and in the tubing, and that was not flushed properly, especially air formation at the connections, at the stopcock connections, or you have loose connections that are sucking air. Those are in pure diagnostic cases. But this happens more often, although still very uncommonly, in interventions. And this is the most common situation. You're removing a large balloon catheter through the TUI host, which can suck air, especially when the guide pressure is damped. That's why it's so important when you're removing a large balloon or a large device from your guide to let it back bleed vigorously after you take your device so you don't suck air. Damped guide sucks air when you open the TUI. Another thing is a trapper balloon we use for over-the-wire catheter exchange. When you deflate it, it sucks air. Also, balloon rupture. When you inflate a balloon and it ruptures and it's not well prepared, you can have air embolism. But usually, if you have impaired flow after balloon rupture, think more dissection from the high velocity jet of the balloon rupture, much more than air embolism. I'll show you some cases from the literature. This is a case reported here where you see the catheter damping before you inject contrast. And that's another hint that the operator here did not recognize. You don't just see air. If you're careful, you will see air, and that will caution you to not inject. That's one way to prevent it, beside the proper flushing. You see air. Number two, when you have those air bubbles, your catheter pressure will be damped. The catheter pressure was damped, but contrast was injected and air went into the coronaries. And so the patient became hypotensive. But it's important to recognize that damping, and don't inject when you're damp. More commonly, because that means you're occluding the vessel and you'll make the patient ischemic, but on occasion it's air. This patient, when air was injected, he went into hemodynamic collapse. And because he went into hemodynamic collapse and cardiac arrest, they used the sucking technique. They aspirated from the guide that air. This was not required in that case because the patient was somewhat stable and the pushing technique distally was working. So there was risk in aspirating through the guide. There was risk in making the patient worse if you aspirate and make that air plug more the left main and the proximal vessels. This is another case from the literature. It's an interventional case. The guide was damped. When they tried to advance a stent through it, they opened the TUI and this sucked air. The guide did not bleed back properly, or they did not let it bleed back properly. So it sucked air, and when they injected contrast to position the stent, they get a lot of air embolism. They just flushed some saline and they were able to stabilize the patient with the pushing technique that I described. So these are some didactic explanation. Depending on how proximal or severe the occlusion, patient may develop chest pain or hemodynamic collapse, VFib, and AV block. Small bubbles spontaneously disperse distally and eventually get absorbed. The air will diffuse into the blood and the myocardium. So ischemia is transient in this case. All you need to do is just support the patient hemodynamically if needed with pressors until ischemia spontaneously resolves. You don't need to aspirate the bubbles in that case. Large bubbles or bubbles causing hemodynamic compromise need to be aspirated or broken down and dispersed. Now, air bubble diffusion into the tissue, into the myocardial tissue, is significantly enhanced by increasing the arterial pressure, which is so important because higher pressure pushes the bubble through the coronary and the capillary. Remember, air bubble embolism can cause you to be hypotensive, which is bad for the patient, but also bad for the absorption of that air bubble. So it's important to be liberal in giving some pressors. Also, air bubble shrinks by increasing O2 pressure in the myocardial tissue. What happens when you give 100% O2, this will decrease the myocardial nitrogen concentration by 90% within a few minutes. And therefore, the nitrogen that is in that air bubble will diffuse down its concentration gradient from the bubble into the myocardium that has now less nitrogen. That's the hypothesis of why 100% oxygen works. So the treatment is 100% oxygen, maintain hemodynamics, be liberal in the use of pressors, atropine, defibrillation, CPR. Those are the most important two. In unstable patient, you can even give intracoronary epinephrine to increase arterial and coronary pressure and push the bubbles. Sometimes CPR, hopefully they don't reach that stage, but if they reach that stage, CPR can disrupt the bubbles. Now, if proximal air is occluding left main proximal arteries with hemodynamic collapse, aspirate via the guide, even your diagnostic guide. If distal air, you can push rather than aspirate, contrast or saline injection. Usually the push technique will disperse the bubble and make it get absorbed. If you get persistent occlusion or if there is hemodynamic compromise that is worsening, then wire the vessel. Wiring by itself can disrupt that bubble and make it absorb more readily. But if that doesn't work, you just wire and then aspirate, advance a thrombectomy catheter and aspirate that air via a thrombectomy catheter. Okay, so this condition is, if properly treated, is always reversible, and distal air is often reversible spontaneously. You just need to support the patient for a few minutes. I'll move on to the next topic. This is a 41-year-old woman, smoker and hypertensive. She presents to an outside facility with near syncope, no chest pain. What do you see on that EKG? She has Q waves in the anterior leads, and she has ST elevation. She also has pronounced ST depression in the inferior lead. It is consistent with anterior STEMI, but can you tell more about that anterior STEMI? Good answer. It's possibly subacute. What else could it be? So the idea here is the ST elevation is not pronounced. So this is an EKG with deep Q waves in V1 through V3 and a mild to minimal residual ST elevation. This may indicate two things. I want you to know those two things. This is a common EKG. One, late presentation at a stage where your ST elevation is spontaneously resolving, or earlier presentation, but you're having a spontaneous recanalization plus or minus on top of pre-existing chronic collateral in so much that ST attenuates. So it's either late or earlier, but spontaneous recanalization. Either way, that EKG, in the absence of persistent chest pain, and if clinically the presentation seems to be more than 24 hours, this EKG does not suggest an absolute need for emergent recanalization. Now, we take the patient emergently, but keep this idea in mind that maybe there is no absolute need for emergent recanalization. That will help you in making downstream decisions as you're doing your coronary angiogram. So she was taken emergently to the cath lab and an angiogram was done. This is an areocranial. What do you see on that angiogram? One thing that jumps at me, there is too much overlap and it's hard to tell what's what. Even, if you're an experienced operator, it's hard to tell what's what. It's even harder for a fellow. Keep that idea in mind. It will be a relevant idea. This is another view here. This is an eleocaudal. And you can see, okay, there is the LAD here. There is a big septal coming. And this is the LAD diagonal. So one thing here, this patient has what I call dual LAD system. You need to be familiar with the anatomy. So the LAD splits in two. It gives a big LAD that gives all the septals, and it gives another big LAD that I call LAD dash diagonal that gives all of the anterolateral wall and diagonal vessels. But what's the pathology here? I'll show you the prior image again. Try to delineate the LAD, and I'll help you here. So this is the LAD here coming. It's giving that big LAD dash septal in a dual LAD system. So the LAD septal that gives all the septals. Then the other LAD, the LAD diagonal, what's happening with it? And when you get lost, you don't know what's going on. Maybe there is disease. Look distally. See where the vessel is reconstituting or forming distally and go backward. Okay, this is the vessel distally. So there is a big lesion here. There is a big, long lesion here. What's the diagnosis here? Just look at that angiogram, you need to be able to make a diagnosis. So this area, and I'll show you the eleocaudal again. Look at it here. And I'll show you more views. This is the proximal LAD. This is the areocaudal. So this is the proximal LAD. And this is that LAD diagonal. Another view here. Again, we see here the LAD diagonal. We don't see very well the proximal LAD. This is a shallow areocranial, but we see well that LAD diagonal. Look at it. It's like a thread. Another thing you notice again is that heavy overlap of vessels and branches. It's hard to tell what's what, and heavy tortuosity. So the diagnosis that should come to mind is spontaneous coronary artery dissection. The context also suggests it. This is a relatively young middle-aged woman, 41-year-old. She doesn't have calcium. She has a lot of tortuosity, and she has a lot of that vessel overlap where it's hard to tell what's what. That's a helpful diagnostic hint to me to think of dissection. Now, what type of dissection that is, and what else makes you think of dissection? Another thing that makes you think of dissection, there isn't much calcium. So it's not a vessel with heavy atheroma burden. Another thing that should make you think of dissection always is the length of the disease. Those are spontaneous coronary artery dissection, type 2 or type 1, they tend to be very long, over 20, usually even over 30 millimeters. Can you tell what type it is, type 1 or type 2? This is type 1 SCAD. Type 1 SCAD is the dissection that is more similar to the dissection we get with balloon and with wire, the iatrogenic dissection, where you see a double lumen or you see a dye stain in the arterial wall with a slow clearing or with dye hang-up. And you see here there is a double lumen. This is the LAD here, the LAD diagonal. You see there is one lumen, and as if you have another lumen at another level. Look at it again. One lumen, you start with one lumen and you end up with another lumen. It looks like the dissection we see with balloon angioplasty. Conversely, the proximal portion of it looks like a clot. Okay, that very proximal LAD looks like a thrombus, especially in this view. It looks like a thrombus, and the rest looks like a dissection with type 1 dissection with double lumen. When you have that combination of feature, you will call it, it's classified as SCAD type 1. Now you have to think, well, could it be just a thrombotic process? It's possible, but the combination of features suggests this is a SCAD. Now, why is that important? Because when you think spontaneous coronary artery dissection and you have TIMI2 flow, so the vessel is open. It has a slow flow, but it's open. Look at that LAD. It goes all the way distally. So when you think SCAD and you're having TIMI2 to 3 flow, you should try not to intervene. SCAD, hemodynamically stable, TIMI2 or 3, try not to intervene, because you can worsen it with your coronary intervention. So it's important to make the diagnosis. Conversely, if it is an atherothrombotic process, then you have to intervene as it is done traditionally in MI. The problem with this diagnosis is that it's made angiographically, and you have to stick to the angiographic diagnosis. So you really have to know the features very well. You want to try not to do wiring and intervention, but you also want to try not to do wiring and IVUS OCT for twofold. 8% of the time when you do IVUS and OCT based on registries, you will worsen the dissection, particularly with the wiring itself. Number two, if you're not experienced, you may not be able to tell SCAD versus atheroma on IVUS and OCT. And I will elaborate more on those ideas. In this particular patient, this was done at an outside institution. They recognized the diagnosis and they decided to stop. This is the RCA. Luckily, the patient has a long PDA that wraps around the apex. 80% of the time, it's the LAD that wraps around the apex. 20%, the LAD stops at the apex. Luckily, this is the case here, so that will limit her infarct size. So they treated her medically. Another thing you should always look for that will strongly support your diagnosis is, do they have peripheral disease, the so-called fibromuscular dysplasia? And you can gather that during your initial diagnostic angiogram by doing peripheral iliofemoral angiography. And here they did the case femorally, and look what you see. You have femoral stenosis in a patient without heavy atherosclerotic burden or calcium. This is strongly suggestive in context of fibromuscular dysplasia of her femoral artery, which will strongly support the diagnosis as well. So let me put all those ideas together and give you some didactic ideas. And I will show you more cases to support that. So spontaneous coronary artery dissection. There are three types. The first type, which is 30% of SCAD, is that intimal tear, similar to what you see in the balloon angioplasty, with wall stain, like here, or 2 to 3 or multiple lumens, as we had. We had multiple lumens. We did not have so much of a dye stain. It may, however, look like a plaque rupture with thrombus. Remember, plaque rupture with a thrombus can look exactly like this, and that's kind of the dilemma in those cases. And that's why the other features help. Middle-aged women, heavy tortuosity, heavy overlap, no calcium, and peripheral fibromuscular dysplasia. Now, type 2 can be even more difficult to diagnose because type 2, there is no intimal tear or intimal split. There is no double lumen or dye hang-up. Type 2 is a bleeding inside the media. It's intramural hematoma. It's that outside-in theory where the intima is intact. The process is all in the media. And it's thought that even type 1, the process may start in the media and that hematoma ruptures into the intima and gives you that double lumen appearance. That's the outside-in hypothesis. But anyway, the pure type 2, what you see typically a long, smooth lesion, refractory to nitroglycerin, and you should always give nitroglycerin before making a diagnosis of type 2 SCAD. The vessels are heavily tortuous yet smooth, no obvious calcium. That idea, by the way, applies even to type 1. Even type 1, it tends to be long lesion on heavily tortuous yet smooth vessels. And type 2, they divide it in two types. It can be diffuse dissection, but it has a clear-cut proximal and distal edges that are free of narrowing, or it could be long disease that extends all the way to the tip of the vessel, distal tip of the vessel. Keep in mind another idea that all those types, type 1 to type 3, they typically affect mid to distal vessel. Most commonly LAD in half the cases, 25 to 30% circumflex, and the least common one is RCA. So, but typically mid to distal, not proximal, 8% proximal, 1.5% left main. That's why SCAD is typically well tolerated hemodynamically, and that's why SCAD typically tend to be benign, especially if you treat it conservatively. So it tends to be mid to distal. Pregnancy SCAD is more commonly proximal and is more commonly much more severe. SCAD type 3 is the most difficult to diagnose, and it is the least common, 5% of SCAD. This type 3 SCAD looks like atherosclerosis. It's more of a focal process, a focal stenosis that looks like atherosclerotic stenosis. To make a diagnosis of type 3, you need OCT or IVUS. For type 1 and type 2, you should overwhelmingly make the diagnosis by angiography. Type 3, what makes you think of type 3? In somebody with a stenosis like this, why would you think of SCAD rather than think of atherosclerotic stenosis? It's those other features. Context, middle-aged women, peripheral fibromuscular dysplasia, and especially, that's always very important for me, those very heavily tortuous vessels with a lot of overlap and no calcium. Those ideas here support SCAD, even SCAD 3. SCAD 3, the only thing, it's not long, but it has those other ideas that favor it. But before making type 3, you need intracoronary imaging. Now, 30+% of SCAD have total occlusion, and they present with a STEMI. Now, if total occlusion, what makes you think of SCAD if it's totally occluded? One, it may be less important to make the diagnosis in total occlusion because you need to wire anyway. Typically, if total occlusion, well, you have TIMI 0 or 1 flow, and the patient is having an ongoing MI. So you typically need to wire regardless of whether it's SCAD or thrombotic occlusion. So it's less important to make the diagnosis. But another thing makes you think of SCAD if total occlusion. Again, those same feature, heavily tortuous vessels, no calcium. And if you have other SCAD feature upstream of the occlusion, you know, you have this morphology or that long, smooth narrowing before the 100% occlusion. Or if you have a SCAD appearance after you wire, you know, you wire it or it's spontaneously recanalized and you get that SCAD appearance. Like I said, it's less important to make the diagnosis in total occlusion, but it's still important because you can wire it and just balloon, not stent it if you think of SCAD. And I will elaborate a little more on that. So some more ideas about SCAD. So typically involve mid to distal coronary segments, most commonly the LAD, and it may be multi-vessel. 10 to 20% you have in the same event, multiple vessel involved. Proximal or left main involvement is rare, hence shock and death is rare, but 1.5% left main. 24% left main in pregnancy SCAD, 40% proximal in pregnancy SCAD. Pregnancy SCAD is much more severe than standard non-pregnancy SCAD. It's overwhelmingly in women, mostly middle-aged women in that 40 to 50s range, but it's also seen in women over 50, and in one large US registry, it was suggested that the mean age of women affected by SCAD is 61. So it may be seen in women in their 60s. It is rarely seen in men. It presents 2/3 non-STEMI, 1/3 STEMI, and total occlusion. It is highly associated with coronary tortuosity. And to me, that's really a quintessential feature of that, including corkscrew coronary artery and a lot of overlap. Now, why do you have that coronary tortuosity? It's an interesting thing. The same collagen fragility that causes wall disruption, whether intimal tear or intramural bleeding, that same collagen genetic fragility also facilitates coronary elongation under wall stress. Furthermore, I would say that elongation of those arteries and that tortuosity can also create kinks in the vessel with whiplash movement, which can trigger dissection. So I think the elongation can also, in my judgment of looking at some of those angiogram, you see a lot of whiplash, seesaw movement, which I think can favor the occurrence of SCAD. Now, SCAD is often initiated by intense exercise. I would say not often. I would say maybe 30+%, whether isometric exercise or heavy lifting or isotonic exercise. Intense emotional stress may also be a trigger, and it was seen in about 50% in patients in registry. So this doesn't help you tell SCAD because those same triggers can be seen in atherosclerotic MI. Very important idea, high prevalence, 30 to 70% of peripheral fibromuscular dysplasia, and it depends on which series. One series suggested 85% prevalence, other more modern series suggest a lower end of that. And it could be renal, iliac or femoral, as in this case, or carotid. And they have a significant prevalence of intracranial aneurysm, 6 to 14%. That has implication on diagnosis. Finding those supports the diagnosis. That has implication also on further workup for those patients. Now, another important idea, traditional risk factors are less common in SCAD than atherosclerotic MI, but do not use those to distinguish SCAD from atherosclerosis, because a good proportion of SCAD have the traditional risk factors, particularly hypertension, which is seen in 30+%, and dyslipidemia, even smoking in teens % of SCAD patients. Only diabetes appears to be very uncommon in SCAD versus atheromatous ACS. Other diseases like systemic inflammatory disease and connective tissue disorder like Marfan syndrome, bicuspid valve, those tend to be uncommon. They are seen in about 3-4% each. So avoid PCIs if possible. Why? Because all registries, whether older or more current, consistently suggest a high degree of failure and complications in over 50% and up to 70% of the cases. Why? Because as you're trying to wire, your wire might go into the false lumen Or your wire might tear that fragile wall and cause an extension of the dissection, including the worst thing that can happen is a retrograde extension of that dissection. And if the patient has TIMI3 flow, you wire it, you may convert him into TIMI0 flow, or worse, convert him into more proximal dissection and make him hemodynamically unstable. In fact, emergency CABG has been required for complication in 13% of patients who attempt PCI. May consider IVUS or OCT in unclear cases, but like I said, there is an 8% risk of dissection propagation with intracoronary imaging, and mainly with wiring itself. So wiring itself, which you need to do to get IVUS or OCT, has its complication. Actually limit your views if you can when you think of that diagnosis, because a just contrast injection can dissect the vessel. This is what we call hydraulic dissection. So the catheter can dissect it by abutting the wall, but the contrast itself can dissect it. And that explains why OCT may be more risky, is more risky than IVUS, because with OCT, you need to inject typically about 15 milliliter of contrast in one shot to remove the blood and allow imaging. Majority of spontaneous coronary dissection spontaneously here on follow-up angiography done over a month, typically around 6 weeks, anywhere between 70 to 97%. So not all heal, but the majority heal. There is maybe about 20, even up to 30% that don't heal. But that spontaneous healing justifies conservative management in patients without active ischemia and with non-critical obstruction TIMI2 or 3 flow. Radial access, in theory, and in some of the series, is more prone to aggravating SCAD and causing left main dissection or ostial RCA dissection in those patients, because you may need to do more maneuvers to engage in radial access. PCI is attempted only if ongoing ST elevation or profound ST depression, total occlusion with TIMI 0 or 1, or cardiogenic shock. And I will add here also if you have left main SCAD. Now, not so much for ongoing chest pain, because dissection itself, like aortic dissection, can cause pain. So chest pain in SCAD doesn't mean ischemia. You have to have something more objective, whether occlusion of flow on angiography or ongoing ST changes or cardiogenic shock. So not so much chest pain. That's why I think in the case I presented, it was the right decision to stop, because the EKG showed mild residual ST changes, which, as I said, could be consistent with spontaneous recanalization. And that was consistent with the angiogram in that patient. So it was the right decision to not intervene. These are some cases from the literature. So this is a case here where this is a SCAD. Look at those heavily tortuous vessels. That's always jumps up to you. Look at that nice loop in that diagonal here. Look at that nice loop again. So they tried to intervene, and this is what can happen. If you have TIMI 3 flow, you intervene, well, they created a TIMI 0 flow. Because why? The wire went into the false lumen. The wire tear here and went into the false lumen. And that false lumen likely propagated distally. So they tried to balloon, but the wire was in the false lumen. They did not reestablish flow. And this is at 50 to 70% failure. And a lot of the time, most of the time, the operator has to stop and leave the patient with an ongoing infarct that is worse than what they started with. Now, here's the problem I have. The biggest problem for me in terms of SCAD, the approach may be well delineated in terms of management, but the biggest and toughest problem is that the diagnosis is solely and exclusively based on angiographic lesion morphology, on the angiogram overall, and on the context. So a lot of us feel uneasy observing tight stenosis without definite diagnostic confirmation. So we need to know very well all the clinical and angiographic clues as follows. It's non-calcified disease. MI with severe coronary stenosis occlusion, but calcium score of 0, think SCAD. If you have somebody who had a calcium score of 0 recently and he comes with an MI, always think of SCAD. Alternatively, he doesn't have a calcium score, but you have the coronary angiogram. You don't see calcium anywhere, not just across the lesion, but anywhere in the coronaries angiographically. Think of SCAD. Middle-aged women up to their 60s, long disease, usually frequently over 30 millimeters, very tortuous coronary, a lot of overlap. That's a massive hint. Peripheral FMD, fibromuscular dysplasia, may help with retrospective confirmation of diagnosis. And I suggest you do it even during your diagnostic angiogram, whether if you're doing it femorally or even radially. You can try to get descending aorta angiogram and femoral-iliac angiogram, because up to 50% of the patient will have femoral-iliac FMD. Always give nitroglycerin before making the diagnosis of any SCAD, especially type 2 SCAD. If total occlusion, it is a little easier because you need to wire regardless. But if extensive SCAD features are seen after wiring, you may just balloon rather than stent. So even if total occlusion, you may stop after wiring, maybe after wiring and ballooning, just after establishing the flow. So you need to know the features of that, even in total occlusion, whether upstream features ahead of the occlusion or features that appear after you open the occlusion. Now, this is an important thing. What do you do in case of doubt? Like even in that first case that I showed you, she had all the features of SCAD. But if you had that appearance of that you see in the proximal LAD, if you had it also in the mid portion in that LAD diagonal, if you had that same appearance, not that double lumen appearance, I would have been concerned about the diagnosis in this patient. That looks like thrombus, maybe plaque rupture with thrombus. So in those cases of doubt, what do you do? One, OCT and IVUS could be done. It was done in around 8% in a Canadian registry. And interestingly, it's about 8% of those who get further complication and propagation of the dissection with OCT IVUS. So you can do OCT IVUS, but AHA and expert reviews do not advocate for it. Peripheral angiography can be done. Like I said, it's very supportive. And like I mentioned, for FMD, you can do descending aortic angiogram, look for femoral iliac FMD, and also renal FMD. I found this to be very helpful. It is important when you make a diagnosis of SCAD, and I will elaborate on the management in a little bit, on the in-hospital management. It is important to do 5 to 7 days of monitoring. Now, this is done because the SCAD can progress. The patient I showed had TIMI2 flow, but in a few days, 5 to 15% of those patients will develop occlusion again and will have a STEMI again. So that's why we watch them for 5 to 7 days, because there is a risk of deterioration before eventual healing. But I found another reason for that. Because I'm usually anxious, is this just SCAD or a thrombotic process? That's another reason I like to monitor them. If there's a thrombotic process, it's even more readily to progress in the short term. So it will give me an opportunity to take them back if there is any deterioration and then intervene. Another thing we can do while they are in the hospital, actually, during those 5 to 7 days after your coronary angiogram, do carotid cerebral CTA and abdominal pelvic CTA for FMD and perianeurysm. That will support the diagnosis. Another thing I always do is CTA, or not so much redo coronary angiogram at 6 weeks. Those guidelines and AHA expert reviews, they favor against redoing coronary angiogram at 6 weeks. They waver about CTA, but that's what I prefer doing. Now, CTA, they criticize CTA because CTA often does not show dissection hematoma features, especially in vessels less than 3 millimeters. And it cannot distinguish dissection from atheromatous stenosis. But I find it relevant on follow-up to see whether there is still luminal stenosis regardless of the cause. I mean, whether this was dissection or a thrombotic process, it doesn't matter. 6 weeks later, is this lumen recanalized? And when the lumen is recanalized, it favors eventually the diagnosis of FMD, even though thrombotic process can recanalize as well, but usually not as often. The thrombotic process doesn't reverse as often. Conversely, SCAD reverses in up to 97% of the time. So I find CTA to be helpful in making a retrospective diagnosis when I see that stenosis has improved. Maybe you're left with 25% stenosis, but that stenosis is no longer 95%. It may even show dissection hematoma if the reader is aware of the possibility of SCAD, so he's looking for it, and if the vessel is more than 3 millimeter. But that may not be the greatest value of CTA. It's just show that the lumen has improved. That simple thing can be very helpful at 6 weeks. A second very important benefit of CTA is that it shows a very low atherosclerotic and calcium burden in SCAD, like IVUS, and this helps confirm the diagnosis of SCAD in retrospect. And this is from the AHA consensus document where they discuss management of SCAD. And again, they do not favor intracoronary imaging with IVUS or OCT. Intracoronary imaging should be pursued only when coronary angiographic diagnosis is uncertain, type 3 or unclear lesion, and when the vessel is large enough for intracoronary imaging. They rely purely on angiogram in the overwhelming majority of the cases. By the way, if you do use IVUS or OCT, you don't need to image the whole vessel. You can wire, you don't even need to wire the whole vessel. You can wire proximally and look for SCAD features in the proximal portion of that lesion. You don't need to look at the SCAD feature throughout. This will limit your wiring and limit your imaging manipulations. This is a case from the literature. It's a great paper, by the way, for you to review. So this is a case where there were doubtful. Is this a SCAD? This looks like double lumen, but again, look, atherosclerotic plaque rupture with a thrombus can look like this. And eventually that was the diagnosis that they considered here. And they had to do OCT and IVUS. Atherosclerosis plaque ulcer with thrombus can cause the exact morphologic appearance. The hint, again, is the context, lack of calcium, lack of heavy atheroma burden, lack of tortuosity. B is another case. It's a total occlusion in a patient with heavy tortuosity. You know, could it be SCAD? Could it be atherosclerotic? In this particular case, it's easier, like I said, when it's total occlusion, I would just wire it. You have to open it. There is an ongoing ischemia, and look for the features after wiring. This is another case where in a young woman where a distal type 1 SCAD was suggested. Young woman, no calcium, that double lumen appearance and long lesion, they thought it's type 1 SCAD possibly. And eventually it resolved with integralin. Now they did a OCT, and the OCT actually suggests heavy atheroma. So this was not actually a SCAD case. This was atheroma. So keep in mind, atheroma with thrombus can look like SCAD. And that's the dilemma we will have going forward. Like in many medical illnesses, you go from underdiagnosis to overdiagnosis. We're still in the underdiagnosis phase, but I worry at one point we will go to the overdiagnosis phase. This patient, 4 weeks later, the patient I showed, she had a CTA, coronary calcium score was 0, and this is the LAD diagonal. And you can see the lumen has improved. It's no longer 95% as in that coronary angiogram. It was read as 50 to 70%. If we give it longer time, it may heal more. This was done at 4 weeks, 6 to 8 weeks, it might heal even more. I have more ideas about SCAD, and I have another case that I want to show you for those who can stick around. So this is a 64-year-old woman. She had a recent calcium score 2 months prior that was 0, no conventional risk factor. She presents with non-STEMI, ongoing chest pain, and troponin of 5. Started at rest, no unusual strain that day. EKG shows interolateral T inversion, no ST abnormality. Now, this is her angiogram. Can you make a diagnosis for any of the fellows here? Is there anything occluded or diseased? Again, the first thing that jumps to me I would say here that there is too much overlap, which again is a hint to me, too much tortuosity, not a lot of calcium, too much tortuosity, too much vessel overlap, hard to delineate where's that LAD. But look carefully, and I can tell you where the LAD is. When you get lost, always look distally around the apex, which in an RAO caudal, the LAD should be somewhere here, not at the border of the heart shadow. It should be somewhere toward the center here. So, okay, there is an LAD occlusion, total occlusion, and there is some reconstitution there. Now, where's the occlusion? Hard to tell. Show you another image. This is the shallow RAO crania. So let's see in a cranial view. Again, too much overlap and way too much tortuosity. Even the diagonals here are heavily tortuous. The OMs are heavily tortuous. I can tell you where the occlusion is here. So one we establish is the LAD that's occluded, and it's look at it distally. When you have occlusion, look at that late filling, at late reconstitution, and try to track back the vessel course from the antegrade filling and that retrograde reconstitution. So the LAD is here reconstituting. And I believe the LAD occlusion is at this point, somewhere here. So this is an LAD that has an unusual course. It dives down, maybe intramyocardially. It gives another diagonal and a septal, and probably the LAD's occlusion is somewhere here, distally. It's an occlusion past the distal septal and distal diagonal. This is another view. And even though I said you don't want to take too many views in SCAD because there's a risk of hydraulic dissection, unfortunately, their anatomy tends to be so difficult with so much overlap that you need to take more views, steeper angles to open up the vessels. So here again, it's hard to tell, but probably the occlusion is somewhere around here in that distal LAD, somewhere here, and it goes all the way there. Here, the operator, this was done again at an outside institution, but I have followed those patients in clinic. So the operator here, it tried to wire it because it's totally occluded, but they failed. I mean, there is not even an obvious stump. Now I'll show you the right coronary. And this is an amazing image to me that goes back to a point I showed earlier. Look at that catheter at the proximal RCA. I mean, that artery is dancing around the catheter. And this is how I think that vessel elongation and corkscrew morphology and tortuosity can cause dissection. It's not just a supportive angiographic feature. It can cause dissection. It's like a seesaw and whiplash effect around that tortuosity. It's not just that the catheter may dissect it. It's just that the artery may dissect itself with every movement. And the catheter is making it more likely here with every injection. And look at this. I mentioned, look at the PDA. It's occluded. And I mentioned multivessel SCAD is seen in 10 to 20% of patients. Actually, more so in pregnancy. It's up to 30% of pregnancy SCAD. So this patient had multivessel SCAD. They tried to wire that as well. They couldn't. They made a diagnosis of SCAD. It's total occlusion. The diagnosis might be, less relevant. They tried to wire it. They failed. The good thing that we're going for this patient is that it was a non-STEMI, no ongoing ischemia on EKG, and she already had collateral to the LAD, and her troponin wasn't very high in the STEMI range. So that's what helped this patient. She already formed collaterals fairly quickly. And they further confirmed the diagnosis by doing the peripheral CTA, and she did have FMD in her carotid. She also had a small aneurysm in her left vertebral artery. Unfortunately, this patient at a CTA done 3 months later, she never recanalized her distal LAD. So recanalization doesn't always happen, as I explained, 70 to 97% recanalized. But she did well. Her apex fully recovered because of the robust collateral flow. Now, I will give you some tips here. Okay, if you need to do PCI in those patients, what are the PCI tips? So one, the PCI goal is not to make it look nice. is not to eliminate the stenosis and make it 0%. The PCI goal is to establish flow. It's okay to be left with 99% stenosis if you have TME2 to 3 flow and no ST elevation. That's the goal. So all you do, try to wire and do low pressure and low size balloon inflation, and try to avoid stenting if you establish flow, especially long stenting in a disease that will heal on its own. You end up with long stent in a patient in a vessel wall that will heal on its own. Why put a stent? The main goal of PCI is to establish flow, not to eliminate the stenosis. As such, balloon angioplasty often suffices as it creates tear in the intima, allowing the intramural hematoma to decompress. That's how balloon angioplasty works. When you balloon an intramural hematoma in dissection, the goal is not to squeeze it. If you squeeze it, you will open an area, but then it will go more upstream or downstream. You'll create a stenosis. You want to avoid that. That's why when you balloon, it's low pressure and low size balloon inflation. And the idea is that you try to tear the intima to make it decompress. Some people have suggested cutting balloon, and you may consider that. Conversely, avoid stenting. One, you have to undersize the stent if you stent. Two, stent may further squeeze that intramural hematoma and cause it to propagate, worsening the flow. Also, what happens is this. Okay, you're stenting, you're opposed, and you're trying to undersize because you don't want to squeeze that hematoma. So you're undersizing and you're opposing it to the hematoma. Well, what will happen a few months later once that hematoma gets absorbed and heals? Well, you'll end up with a gap. You'll have a free-floating stent in the lumen. This is the so-called late stent malapposition, which is common in thrombotic STEMI after the thrombus resolves and dissolves behind the stent, but it is more prevalent and more dramatic in SCAD. So late stent malapposition. So really avoid stenting as much as you can in those patients. Now, CABG. When should you consider CABG? There is a problem with CABG. CABG is hampered by distal vessel involvement. Like I said, it's 92% of SCAD are distal. So you may not have a great target. You may not have anywhere to sew the graft on. And it's hampered by the high rate of graft closure on long-term follow-up as native diseases regresses. So you put a graft on a 90% LAD, but that 90% will resolve. So that graft will occlude because you will have good native flow. So those are the problem with CABG. However, CABG is still valuable in cases of left main or multi-vessel SCAD, and the patient is having ongoing STEMI that you could not open, ongoing STEMI in a large territory, or hemodynamic compromise. Even though the bypasses will shut down eventually, it's still valuable as a bridge. It's a temporizing measure to reduce serious clinical complications while the vessel heals. And I agree with Dr. Rassen's point. A lack of tortuosity does not rule out SCAD. In the literature, I showed you 78% of SCAD in the registries had tortuosity. So not all have it. But to me, if you don't have tortuosity, you may have SCAD, but I'm more willing to do IVUS OCT and take a risk to prove the diagnosis. So you understand the importance of those features. The less of them you have, the more you want to do IVUS or OCT. Those features I showed here. The less you have of them, the more you want to do IVUS or OCT, because it could be just atheroma with plaque rupture. Since I mentioned IVUS OCT so many times, well, I want you to see how they look on IVUS and OCT, because that will become, maybe as we start recognizing SCAD more, we'll be doing more. So this is how it looks. Typically, it's a crescent shape, or you can call it a banana shape. It could be circumferential, or it could be crescent shape, banana shape. It tends to have on IVUS and even on OCT that white, black, white morphology. You can see that morphology, white, black, white. So it tends to be homogeneous, white, echogenic, and it becomes darker with dark speckles as you go deeper. And this is, again, it's well demarcated, somewhat homogeneous, although darker deeply with a white sequence, semi-lunar or circumferential shape. Those are some other examples from the literature. Look at that. This is a classic morphology. It's not always that nice, but whenever you see that, again, white, black, white, whenever you see that, this is very characteristic, whether on OCT and IVUS. It's very characteristic of intramural hematoma. Again, when you're suspecting it with the other features as well. It's not as obvious in IVUS, and I'll show you, because sometimes you have multiple lumens, especially when I told you a SCAD type 1, by definition, you have multiple lumens. That's the angiographic features. It may be harder to diagnose. Again, you'll have that crescent banana shape. You see it very well here, but you may have other pockets. You see another pocket, another lumen there. So it becomes hard to diagnose. Maybe those pockets, this is a lipid-rich or necrotic core plaque that has ruptured and thrombosed. So it may be atheroma and the thrombotic process. It's even more difficult in this case. The authors of that paper considered it SCAD, but for me, I would have thought this is a lipid-rich or necrotic core plaque that ruptured and occluded the vessel. That's what I would have thought here. So OCT generally has better resolution and it's better for diagnosis, but it has a higher risk of dissection. So I think a lot of operators, including myself, would prefer IVUS, but it's easier to analyze. It's more difficult, lower resolution, more difficult to analyze the images. If you do IVUS, don't use the phase array volcano system. It has even lower resolution. Use the Boston mechanical transducer. Some idea about the in-hospital management and other management here, aside from the decision of conservative and monitoring. So conservative treatment consists of what? Aspirin and beta blocker therapy, along with 5 to 7 days of inpatient monitoring. Because of that risk of progression first week, or if SCAD diagnosis is uncertain versus thrombus, atheroma and thrombus, that 5 to 7 days is very valuable for that. Avoid therapeutic anticoagulation per AHA document and all the reviews I've seen. So if you were on heparin before the cath, stop it afterward. The idea here is it's an intramural hematoma. So some degree of antithrombotic therapy is required to prevent thrombosis of that compressed true lumen, because you can have SCAD and thrombus in a vessel that has impaired flow. You can get secondary thrombus. So you need some antithrombotic therapy, but too much antithrombotic therapy risks extending the false lumen hematoma. Hence, only antiplatelet therapy is typically used, plus or minus clopidogrel early on. I will show you the controversy about Plavix. Plus or minus, if you use anticoagulation, a DVT prophylaxis dose, not full therapeutic anticoagulation. No integralin in those patients, and no benefit of statins in those patients, although no harm either. Registries have shown that statins have not improved outcomes in those patients because they don't have atheroma. The acute mortality is low, so SCAD is a very good prognosis. Non-pregnancy SCAD has a very good prognosis. In most registries, the mortality is close to 0%. In the Canadian, which is the largest registry, is 0.1%. 5 to 15% may have acute SCAD extension in that first week, like I said, and that's why we monitor them before eventual healing. They will have EKG signs of ongoing or recurrent ischemia, which justify repeat coronary angiography or CT. Persistent pain by itself does not necessarily imply ischemia, as a dissection process may be painful by itself. You need EKG to document recurrent or ongoing or progressive ischemia. As I explained, may do follow-up CTA or less favorably coronary angio at 6 to 8 weeks to document healing. JACC state-of-the-art review recommends against routine angiography in asymptomatic patient after SCAD due to the risk of iatrogenic dissection with every coronary angiogram you do, up to 3.4% risk of ostial coronary dissection, coupled with a high rate of healing of conservatively managed SCAD. I mentioned the high prevalence of FMD. You need to do for those patients abdominal CT and carotid cerebral CT angiography. One, because it helps retrospectively support your diagnosis, but two, because it may imply management if you have significant carotid obstruction or big berry aneurysm in the brain. Long term, there is in the 10 to 20% risk of recurrence at 1 to 3 years. So there is a risk of recurrence, and up to 30% at 5 years. Those numbers vary by registry, but there is a risk of recurrence. There is a higher number than that of a recurrence of ED presentation for pain. So they tend to have recurrent pain, but a lot of that recurrent pain is not extension of SCAD. So recurrence is reduced by beta blockers. This is the most important treatment. It reduces recurrence by 2/3, and by avoiding emotional and physical triggers such as heavy lifting, Valsalva, and possibly, although this is debatable, hormonal therapy. Regarding Plavix, there is only one good study. It's not a randomized trial. It's from a registry published in EHJ in 2021. It suggests that DAPT is associated with more adverse events at 1 month and 12 months than single antiplatelet therapy. This is driven by an early excess of non-fatal NMI and unplanned PCI. So limit clopidogrel use. If you use it limited to 1 month, maybe even a few days based on that study, while hospitalized only. And that's kind of what I have favored in those cases I've been involved in. Maybe use it during that hospitalization only. These are some of the references you can review regarding that topic. I get my numbers from some of those references. I want to give a note about pregnancy SCAD. Pregnancy SCAD is much worse than non-pregnancy SCAD. It's more proximal involvement, like I said. Left main involvement in 24% of the patient in the Mayo registry, proximal vessel 40% in Euro registry, whereas in non-pregnancy SCAD, left main is 1.5%, proximal vessels are 8%. Consequently to that, you have more STEMI, also more total occlusion, more multi-vessel involvement, more cardiogenic shock up to 24%, and higher mortality. Instead of 0%, it's 4%. Now, when does pregnancy SCAD occurs? It's overwhelmingly in that first month, especially the first couple of weeks postpartum. It can happen in the last month of pregnancy. It can happen later on, up to 3 months, but it's really overwhelming those first few weeks. It happens more readily in older multiparous mothers. Generally, it's recommended that if those patients get pregnancy SCAD, not to get pregnant again. Interestingly, even if a woman has a non-pregnancy SCAD, it's strongly suggested that she doesn't get pregnant because it's believed that she will have a high risk of SCAD during pregnancy. Keep in mind another important idea. SCAD is responsible for 40% of pregnancy-related MI. Another 40% is related to atherosclerotic plaque rupture and thrombus. Then you have a smaller percent related to in situ thrombosis and to vasospasm. So not all MI-related pregnancies are SCAD. And SCAD tends to predominate in that postpartum, whereas antepartum MIs tend to be more atherosclerotic MIs.